Wait for my cue. Thank you, Jamie. And our didactic topic for today is decreasing the risk of side effects and other metabolic conditions. So objective-wise, we're going to list the metabolic condition. So specifically, what is it that we're most concerned about? We'll discuss some interventions that may help reduce the risk overall, and this is outside of the use of any of our antipsychotic medications. And then we'll look at what might be some of the specific strategies. So how can we minimize these adverse effects, maybe catch them early, prevent them overall, or address them once they pop up? So let's start by looking at metabolic conditions. So what exactly is it that we're talking about? The general definition are that these are medical conditions that affect aspects of metabolism. So the body's ability to take in all of the signaling related to your appetite, what it does processing, and then mobilizing and actually using the energy and the fuel that you're getting from your diet. So why might those be a problem? Well, because many of those conditions actually can come together and create a number of other medical conditions if they are out of whack. The biggest concern is related to something called metabolic syndrome. So obesity, specifically abdominal obesity, meaning that all of the weight collects right around your waist, as well as high blood sugar tend to be the two biggest ones that are a focus of the metabolic conditions. But they are very intricately linked to changes in cholesterol panels, so high triglycerides, low good cholesterol or high density lipoproteins, and then high blood pressure. So recognizing that we can't just look at weight and blood sugar, which are going to be targets of side effects for our antipsychotic medications, but they actually are linked to a number of those other conditions. When all of them come together, it significantly increases the risk for cardiovascular disease. So patients are at risk for having heart attacks. They may be at risk for having strokes, for having other complications as a result of that. When sugar levels are off, when cholesterol levels are off, high blood pressure that's uncontrolled can cause problems with vision. It can cause problems with circulation, maybe sensations. It may result in infection if we can't get blood down to certain parts of the body. It also can cause damage to some of the other organs in the body, including the kidneys. So if we damage the kidneys, then the body really can't filter through the blood as efficiently as it should. So it can start a whole cascade of a number of other medical problems that could very quickly become overwhelming for some of the patients. So why was this the focus? Why are we most concerned in taking a peek at this? Well, because individuals who have severe and persistent mental illness have been identified to pass away earlier than the general population. Depending on the cohort study that you look at, it's anywhere from 1 to 3 decades before their same age counterparts. So for individuals who are 50, that means their life expectancy, if they do have a severe and persistent mental illness, may be much shorter. And it's because of some of these conditions. Now, I don't want you just to take my word for it, so let's look at some data related to that. So there were 2 really large studies that have been done that include a relatively robust cohort of individuals. So one was the CATIE trial. So this was clinical antipsychotic trial of intervention effectiveness. So this took patients who had severe mental illness and were on antipsychotic medications. They followed them for 18 months. They were put on a number of different antipsychotic medications, and we were able to collect a lot of important information. So that's really our population that has mental illness. They compared that with data from the National Health and Nutrition Examination Survey. So this is a national survey that goes out on a regular basis that samples the general population. So trying to compare those that have a mental illness, yes, they were on antipsychotic medications with just their counterparts in the general population that don't have a mental illness. So what they found is that conglomeration of symptoms that we just talked about that increases the risk for things like heart attack and stroke. For men that had mental illness, 36% of them met those criteria. A little less than 20% in the general population that were the same age met that criteria. For females, it was even more significant. So 51% of those with mental illness met the metabolic syndrome criteria, where only 25 of those in the general population did. So they were much more likely to have all of those issues, which means that they're at much higher risk. For each of them individually, if you look all the way down, so waist circumference, so that obesity being right around your middle, problems with cholesterol, so high triglycerides, low good cholesterol, that HDL. Again, all of those who had mental illness were more likely to meet those criteria than those that were in the general population. And similar with the females as well. For blood pressure, we see the same across the board, as well as for glucose. Although this one, at least for the males, didn't show quite as much of a difference. So they were pretty close in the glucose category. That wasn't the one that really was driving the difference. So it means that individuals, we know that these conditions can cause a number of other medical complications. They potentially can shorten lifespan, and they're more likely to happen in this population. We're going to add to that. One more thing just to look at that. So this also was the Katie study data. So 18 months of patients who had mental illness. And they also compared it to general population. And this is a little bit small on the screen, but if you see all of these lines, so this is the mortality rates. So how many people passed away over this set of years. So it was 93 to 2012. The blue line is due to circulatory problems, so any type of heart problem or heart disease. The red line was due to cancers. The green dotted line, is due to metabolic considerations, things like complications from diabetes. So all of these medical conditions, the box on the left are patients who did not have a mental illness, those that did not have schizophrenia. The box on the right is for all the mortality rate, all the patients who passed away from these causes in patients who had schizophrenia. Across the board, those patients who did have schizophrenia were passing away more frequently due to these same conditions. So really putting them at high risk, which means that we need to be targeting this population to make a difference, to be able to bring that risk down. We're going to add to that. So the fact that they're at higher risk is a problem, and they were at higher risk to begin with. So there are a number of different studies that have been done that look at patients who have a mental illness who are treatment naive. So they've not been given antipsychotic medications yet. They tend to be more likely to be overweight or obese and to have sugar problems. So maybe their sugar levels are high, or that they're not as sensitive to insulin as we would expect. So they already have that coming in. And then we put them on medications where the adverse effects include gaining weight, having high sugar, and elevating your cholesterol. So we take those risk factors and make them even worse by adding the medications on board. So what are we going to do about that? So that seems like that really is a pretty significant risk that we're putting these patients at. So things we can do before any issues pop up. So before the patient has a diagnosis of diabetes, of high cholesterol, before any of that, it's really, really important that all of the patients are established with a medical provider. So having a primary care provider or a family practice provider is vitally important. Somebody who can help direct traffic, as well as be screening for all of these things along the way. They also can help house the information related to personal and family medical history. So if you have a medical history of patients in your family who have had heart disease, may have had heart attacks at a young age, or developed diabetes, that's really important to know, because that means your risk is a little bit higher. So maybe we're going to pay a little closer attention, or test you a little more frequently, so that we're catching that ahead of time. We can start early with things like education on nutritious choices, within reason, recognizing there are some limitations to what everyone is able to access in terms of food. Encouraging physical activity as much as is safe in their current environment on a regular basis. Encouraging at least a routine physical exam. So I know that in the past, there were many individuals who would say, I don't need to go to the doctor, I'm not sick. Okay, well, we don't want you to wait until you are sick, because many of those conditions are quiet. they're really not going to have many symptoms that they would notice, even though that disease is going on in the background. So that at least once a year check-in can be really, really effective at identifying, okay, hold on, sugars aren't where we want them to be. Your cholesterol isn't quite where we want it to be. We don't want to wait until you have something like a heart attack or a stroke to know, oh, hey, your cholesterol's way out of whack. The last piece is open lines of communication. So ensuring that those discussions about general health topics are absolutely 100% on the table. And that's before they have any of those problems. That really allows the opportunity for when things do pop up that they're willing to have some of those conversations. This also helps us move into more of a proactive state where we're trying to make changes before we see that there are issues, and then we're a little bit more forced to make some of those changes. Now, that does not take into account the antipsychotics. So the role that the medicines play, obviously that increases their risk. So what are we going to do about that? That is a great question. So step one is going to be, again, to be proactive. We don't need to wait until those side effects pop up. Start having some of those conversations. And I recognize that for some patients, it may be a very significant upheaval in their lifestyle. So they have their psychosis symptoms are out of control. Maybe they end up in the hospital. Maybe their housing situation is changing. Maybe their employment is changing. With all of those things changing and adding a medicine on board and then asking for the lifestyle changes, that can really be a lot for an individual to try to take on, even if they have a wonderful support network. So having those conversations ahead of time, laying the foundation before there's even an issue can really be helpful, because maybe some of those practices will already be in place so we don't have to worry about trying to make those those additional changes, what they're eating, how they're eating, when they're eating, all their physical activity, while they're also trying to manage some of these new, maybe more out of control psychosis symptoms. Same with the medical screenings. Having baseline information on what their weight is, what their waist circumference is, what their sugars look like, their blood pressure, their cholesterol can be vitally important, because that gives us something to compare to once the medications have been started. So if we already have that information, that's one less blood draw we'll need to do while the patient's either inpatient or having to start their medication. So start early, don't wait. And check regularly. So the consensus guidelines were developed by the American Diabetes Association and the American Psychiatric Association, and they were developed more than 20 years ago now. So we really should be following this relatively closely, checking in on patients on a regular basis, checking their weight. So knowing their height and their weight can give us what their body mass index is. So that tells us if somebody's overweight or obese, but also checking around their waist. So maybe the scale is only moving a little bit, but all of that is packing right around their waist. That's the worst place for that extra weight and adipose tissue to be. So if the fat tissue is concentrating there, that increases the risk that they may potentially develop a cardiovascular disease. So we don't want them to have heart problems at all. And if we know that that's where the weight's going, then maybe we need to be a little bit more intentional about making some of those other changes. Checking blood pressure, checking glucose, checking cholesterol, that lipid panel. We definitely need to be doing that by 3 weeks. So one of the reasons we don't check this earlier is because if we check it too early, especially with the sugar and the cholesterol levels, we may not catch that there's a change. So if we're checking that only a month out, maybe there's only a smidge of a change and that doesn't look like it's much of a difference. Maybe I was paranoid before, I wasn't eating hardly anything. And now that my psychosis symptoms are under control, I'm eating regularly. So you see a little change and we don't think that's as much of a problem. Well, that might be a trend that's going to continue to increase. So we need to make sure that we give it a long enough period of time to work and for there to be an effect that we can start to measure. If there are problems, so if something pops up and it's not quite where we want it to be, then we need to be checking those more regularly. But having already an established check-in point with that blood work really can be helpful so that we have a stopgap measure to be like, yep, we're going to check on this now. and then we can see when we need to check on that again moving forward. Ideally, we would like it to screen things out. If we can catch and see, hey, things are starting to trend in the wrong direction, first recommendation is still going to be those lifestyle modifications. I think all of us can take a peek at what our current situations look like and know, you know what, I probably could do a little better in some of these places. So that would be the first step if we start to see increases in weight, increases in blood pressure, increases in sugar or cholesterol levels. I encourage you to reach out. This isn't something that needs to be just on the mental health treatment team. So does the insurance allow for a referral to a nutritionist, a dietitian, a personal trainer, somebody in exercise science, if they start to have some of these problems? So we recognize that's an issue. Can we get at least a referral? That's what they do. That's where they focus. And they may have some really good outside the box recommendations that can fit whatever lifestyle the patient has. So I would encourage you, yes, we may have thought we did everything we needed to do, but can we look and pull in a couple other folks to get some additional perspectives? Other things, and we'll talk about these a little more specifically. So we need to talk about the antipsychotics. So if they are contributing to the development of some of these conditions, then we need to open that discussion. And then targeted therapy. So if these conditions are here, so the sugar is out of control, now we need to do something about it. So what might that look like? The antipsychotic discussion is not going to be an easy one. There are a lot of, and that's where the open communication can be super helpful. There are a lot of questions that need to be addressed. So sometimes there are some of our medications, risperidone, olanzapine, clozapine. It seems that the metabolic adverse effects might be dose related. So is it possible to lower the dose a little bit, and maybe we'll see if we can get a better handle on some of those side effects? Maybe the weight gain stops. How long have they been on this medicine? So if they've only been on it a short time and we're seeing a lot of weight gain, that might be a big problem for the patient. They say about 5 to 7% of a change from their baseline body weight. So once we hit that 5% change from baseline, that's the point where, yeah, we really need to make an intervention. So if we can catch it beforehand, that can be really helpful. Although if it's starting to trend up early, that kind of means we're probably going to need to do something. We want to be thinking ahead. However, antipsychotics are not all created equal. So some patients respond better to medicines than others. Have they tried other medicines? Is this the only one that works for them? Is this a good fit in terms of what the other adverse effects look like? So all of those are going to need to go into the discussion about whether or not we swap out this medication. In some cases, the answer may be yes. Yes, we can move to a different medicine that's less likely to cause these adverse effects. None of them have no risk. So they all carry some, but some of them are more likely than others. Or the benefit of having the psychosis symptoms controlled really outweighs everything else. So we need to make additional interventions. If we're going to make changes for both weight, this is, I think, the best depiction, but it's the same for cholesterol as well as for sugar levels. Some of the medicines some of the antipsychotics are much more likely to cause problems with weight gain, problems with sugar, problems with cholesterol than other medications. So the discussion can be, we can try you on something different. My word of caution, I had worked for a long time with patients who had developmental disabilities, and I had patients who gained a significant amount of weight on medicines like risperidone and aripiprazole. So if you see ziprasidone down here, the third one over from the left, it looks like it's no weight change. Well, on average, people don't tend to gain a lot of weight. There are patients who do. So our discussion about that needs to be very realistic. We're going to move you to something that's less likely to gain weight, but we're still going to monitor because there is still a chance you will gain weight. If we tell them, no, we're going to move you to this and you're not gaining weight, and then they gain 30 pounds, you've lost all your credibility. So just keep that in mind, that all of the medicines, old and new, first and second generation, all cause more weight gain compared to placebo. So that is an option. again, we want to keep track of those psychosis symptoms, make sure we keep those under control, because if those are out of control, then on the adverse effect side, that may not make as much of a difference because we'll need to make some additional interventions. But that could be on the table. The other option that might be on the table if switching is not a good fit for the patient is let's treat what's happened. So if it's weight gain, we have a number of medications that have been studied in antipsychotic-induced weight gain. Metformin has the best data. It's traditionally a diabetes treatment medication. However, it is moderately effective for helping reduce some of the weight gain for patients who have gained weight with antipsychotics. That new class of medications, the GLP-1s, the glucagon-like peptide-1 agonists, things like semaglutide, they are very effective. We see all of the commercials for weight loss. They can be used for weight loss. They also can be used for antipsychotic-induced weight loss. And they appear to have a relatively robust effect size. So they can bring the weight down pretty significantly. They are injections. Supply may be problematic, and some of them may be expensive. So yes, they can be effective, but that may not always be the best fit for all of the patients. We have a few other options. Topiramate or Topamax is in some weight loss medications. It's been used by itself with antipsychotics, and then Orlistat and amantadine. Those are a little bit farther reaches, but I just really want you to know that we've got options to try to assist with the weight gain. None of these will bring their weight to normal all alone, so we need to make sure those lifestyle changes, so diet and physical activity, are also in place with these medications. How about for sugar levels? We've got a lot of treatment options for patients who may start to develop diabetes. Let's work with the providers, the medical providers, and say, okay, so what's going on with their sugar? What would be the best fit to help get their sugars back under control? But there are a large number of options that we could potentially use. And the same goes for cholesterol. So taking a peek at what does your lipid panel look like and where do we need to target? Improving, maybe bringing down what your triglyceride levels are, bringing down your bad cholesterol. So we have options to specifically treat cholesterol that can help bring those down, which means you can stay on the antipsychotic that was effective, and we also can reduce your risk for developing some of those other complications as a result of having uncontrolled cholesterol. Makes the medication list a little bit busier. However, if we're trying to really meet the patient where they are, if the best interest of the patient is keeping them on what they're on, then this really needs to be the path that we need to follow. Allowing those levels to just be unchecked is what got us into the situation that we're in, which means that their mortality risk is significantly higher. So just to wrap up, this is a significant concern. It's not just due to the meds, but the antipsychotics side effects definitely make that worse. So it increases the risk for all of those medical conditions, which could unfortunately increase mortality for this population. The more proactive we can be, the better off. However, if we're unable to be proactive and it happens anyways, then really starting to go down the path of targeted treatment to get those conditions under control is going to be in our best interest. So with that, I will turn things back over.